Well, thank you very much for that kind introduction, and thank you to the Royal College for inviting me here today to talk to you more about delirium. Traditionally, delirium has been slightly sidelined, both clinically and in terms of research, as it was thought to be a relatively benign and transient condition. We now know that this is not the case, and I'll cover this today in my talk, as well as discussing the results of my PhD, which explored cognitive outcomes after delirium and aimed to answer this question. Hopefully, by the end of my talk, I'll convince you all that delirium cannot be overlooked, and I'll provide you with some useful hints and tips to take away about recognising delirium. I'm sure whichever specialty you work in, you see a lot of delirium, but I thought it'd be useful to start with a case. Mrs. Smith, not her real name, is an 87-year-old lady. She lives alone as her husband died 6 months ago. Her daughter rang for an ambulance after finding her very confused and not letting her into the house. Unfortunately, her daughter wasn't able to go to the hospital with her as she had to pick her grandchildren up from school. When she arrived in A&E, Mrs. Smith was very distressed and wouldn't let the doctors examine her. They did manage to get blood somehow, which showed that she had a high white cell and CRP and deranged LFTs, and she was admitted under the medics with query cholecystitis, and she was noted to be a poor historian. Unfortunately, there were no medical beds, so she was boarded to a surgical ward. Mrs. Smith remained very settled on the ward and slept for long periods during the day and night. Massive alarm bells. When her daughter visited, she was concerned about how confused her mum was, but unfortunately the doctor responsible for her care wasn't on the ward as she was a boarder. 7 days later, she just got better. She was eating and drinking and her bloods were settling, so she was discharged home. Her discharge letter stated, admitted with cholecystitis, managed with IV antibiotics, generally improved, ultrasound suggestive of cholecystitis, and the GP was asked to recheck her LFTs and start the statin accordingly. No mention of her presenting complaint. Once back at home, her daughter kept a close eye on her. Her daughter took over doing things like the finances and her weekly shopping. She was worried about her mum because she was still more confused, although much better than she had been immediately prior to her hospital admission. But she was unsure what to do now and whether this was just normal at her age. So I think you'll agree this is a fairly typical case, but raises some important points. Firstly, did she have delirium? If she did, it certainly wasn't recognised, it wasn't documented, and it wasn't communicated to her daughter or to the GP. Does she now have an undiagnosed dementia? There are certainly hints to this in the case with her daughter taking over some of her more complex tasks, such as finances and weekly shopping. Did she have dementia before she came into hospital that just hadn't been noticed? It's not uncommon for fairly significant cognitive impairment to be unmasked by the death of a spouse. It's only then that you realise how effectively they worked as a team. Generally in the case though, there's lots of anxiety, lots of missed opportunities, all because delirium wasn't recognised. And actually, as you're about to find out, Mrs. Smith may not do very well over the next year or so. So what is delirium? Well, delirium's been described for thousands of years, but since 1980 it's appeared in the DSM criteria produced by the American Psychiatric Association. In the absence of a biomarker, the gold standard for delirium diagnosis is the fulfillment of the DSM-5 criteria, and all 5 of the points A to E must be met for a diagnosis to be made. I've highlighted some of the key components of the criteria. Firstly, a disturbance in attention, so your ability to focus, sustain and shift attention on a particular task. So often you can spot this when you're talking to people because they are very distracted and don't seem to focus on you properly. And actually talking to someone who's very inattentive is incredibly frustrating. Delirium also affects awareness and level of alertness. So some people can be unusually withdrawn and sleepy, which we call hypoactive delirium, and some people can be the complete opposite and sort of never sit still and be pacing around, and we call that hyperactive delirium. Delirium's acute, often coming on over hours to days, and tends to fluctuate, often being worse at night. Delirium also affects cognition, and often that affects memory or orientation. And we test this by asking people things like where they are and what day it is. But it's important to remember that delirium can also affect perception, and people can see and hear things that perhaps are not really there, and that can be particularly distressing. The disturbances in A to C must be new and not due to an underlying condition. And finally, point E states that there must be a medical cause for the symptoms. In summary, delirium is a sudden onset of confusion, which specifically affects attention and level of alertness. Crucially, most dementia does not affect attention and level of alertness, even in the advanced stages. The exception to this is dementia with Lewy bodies, which does show considerable overlap with delirium. In people with dementia, but particularly people with dementia with Lewy bodies, the collateral history is key, and relatives will often say things like, they're not normally like this. It's so important to listen to relatives and recognise this change, as in people with dementia, delirium may be the only presenting complaint of a serious and treatable underlying cause. So what does cause delirium? Well, there's rarely just one cause to delirium, and it's usually due to the interaction of a number of factors which make someone vulnerable, and a number of precipitating factors. So, for example, someone who's older with cognitive impairment, who's frail with visual impairment, so a lot of people that we see in hospital, has a very high vulnerability, so they need a very small precipitant to push them over the threshold of getting delirium. So something as simple as changing one of their medications. However, someone who's young with none of the factors that make them vulnerable has a very low vulnerability and therefore requires a very large precipitant. So something such as a big trauma with lots of surgery and a prolonged stay in intensive care. Crucially, delirium is preventable in over a third of cases. So as I'm sure you're aware, delirium is really common. A point prevalence study from Ireland, which examined all adult inpatients in a particular hospital, a 400-bedded district general hospital, found that 20% of all adults in the hospital at any one time had delirium. They found that the prevalence increased with age, with 35% of those over 80 affected. It's really important to remember that delirium is really distressing for the patients, for their relatives, and for the staff looking after those patients. This excellent paper summarises the studies that exist regarding distress in delirium. A lot of the studies are in ITU populations, but they found that delirium was associated with considerable short-term distress, as well as things like post-traumatic stress disorder, anxiety, and depression in the longer term. As part of my study, I followed people up a year after their hospital admission, and I found that the delirium was often the only thing that people remembered about their hospital admission. I had a lady who was heroically saved by one of our consultants, and had lots and lots of treatment in hospital. And when I saw her a year later, the only thing she could remember about her hospital stay was that when she went to the toilet on a number of days, there were cats all over the floor, and she thought this was disgusting and she didn't want to go back to that hospital. They found, though, that information provision was really helpful in reducing distress, both at the time that people have delirium, but also potentially preemptively in a sort of preoperative scenario. Delirium is expensive, often due to the increased risk of complications such as pressure sores and aspiration with hypoactive delirium and falls with hyperactive delirium, all resulting in an increased length of stay. Delirium is also associated with poor outcomes. This excellent meta-analysis included 51 studies and showed that people with delirium were considerably more likely to be discharged to a care home. You may think that the people who got delirium were just more vulnerable and so more likely to be discharged to a care home, but they controlled for age, baseline cognition, illness severity, and comorbidity in their analysis. This same study showed that delirium was also associated with increased mortality, and they showed a hazard ratio of 1.95. What does that mean in practice? Well, I've sort of shamelessly stolen this slide from a colleague of mine in Birmingham, Thomas Jackson, who's done a lot of delirium research. I think it's really powerful. So these two chest x-rays represent two people with pneumonia. They're both the same age, they both have the same baseline cognition, the same comorbidities, and the same illness severity. The one on the left has delirium and the one on the right doesn't. The one on the left is twice as likely to die as the one on the right. There's a really good reason why confusion is a key component of things like the CURB score. It should really be the DERB score for delirium, but anyway, never mind. And actually, the Royal College have included confusion in the NEWS2 score, and it now scores you an automatic 3 if you've got new confusion, which results in a review. This just shows how important delirium is as a marker of adverse outcome. What we know far less about is the impact that delirium has on cognitive outcomes. And this is the million-dollar question. This is what Mrs. Smith wants to know in our case, and this is a question that I got asked a lot clinically. And this provided the focus for my PhD, which was called the DECIDE study, Delirium and Cognitive Impact in Dementia. People have obviously looked at this before, but their studies had a number of key limitations. Firstly, a lack of generalizability, so often people selected patients that just weren't representative of the ones we see, so often elective cardiothoracic patients were quite easy to follow up, but just not representative of people we see. Secondly, a lack of knowledge of people's cognitive baseline. So if you follow up a load of people with delirium, lots of them then get dementia, but actually probably quite a lot of them had dementia beforehand. And thirdly, a lack of prospective delirium assessments, meaning that you couldn't control for the confounding effect of illness severity at the time. So is it just that people who got delirium were sicker, and it was this that resulted in their cognitive impairment? Or is the delirium itself doing something, and is it neurotoxic? And that's one of the big unanswered questions in the delirium world. So my study aimed to measure the effect on cognition of an episode of delirium independent of baseline cognitive status and illness severity. So how did I do that? Well, I was very fortunate to be based in Newcastle, which is one of the Centres for the Cognitive Function and Ageing Study 2, or CFAS2 for short. This is a population-based study which was sampled via GPs, therefore it's as representative of the general population as you get in a cohort study. All of the people in the study have been seen twice as part of CFAS2 for cognitive assessments, and so when I came to do my analysis, I knew their baseline. And when I started my study back in sort of the end of 2015, there were 1,328 of these people still around. During 2016, if any of them came into hospital, I was alerted to their admission by an alert on the electronic medical record system, and I went to see them and asked them if they wanted to take part in my study. And if they or their relatives were happy, I went to see them regularly during their hospital stay to see whether they developed delirium. When I went to see them, I carried out a sort of semi-structured interview, had a really nice chat with them, and also got some collateral history from nursing staff or family if they were around. And this enabled me to use a standardised approach to determine whether they had DSM delirium or not. And this has all been published, and that's the reference if you want to know more about what I did. I followed up all the people that I recruited in hospital a year after their discharge and repeated the same cognitive assessment that they'd had twice before. So therefore, we had before and after memory test scores in people who did and did not develop delirium. So what did I find? Well, this is currently preliminary data and is unpublished at the moment, so please no tweeting it, we're just writing it all up at the moment. Essentially, this is my recruitment flowchart. I'm not going to talk you all the way through it, but there's some key points to pull out. Firstly, you'll notice that just over a quarter of my representative cohort of people in Newcastle over the age of 65 were admitted during a year. So this is a huge number. Secondly, you'll notice that my recruitment rate was nearly 75%. And I think this demonstrates that it's not only possible to recruit older people, my mean age was 82 and my eldest participant was 99, but the older people and their families are really keen and receptive to doing research even when admitted acutely unwell. So 40% of my 205 participants got delirium during the year, and I had outcome data available at a year for 173 of my participants, so it's possible to look at predictors of outcome and whether delirium did predict any poor outcomes. So what did we find? Well, again, this is preliminary data, but the messages that are coming out of the data at the moment are that delirium independently predicted new dementia, declining cognition, and poor outcome, which we group together as either death, dementia, or institutionalization. So mirroring other studies that have been done, delirium is bad. So going back to my original question, is my mum going to get dementia? Well, she may already have dementia, as we've mentioned. So Liz Sampson's study from London assessed all people over 70 admitted as an emergency and found that 42.4% of them had dementia, and only half of them had a diagnosis. So there's loads of undiagnosed dementia out there. Delirium may be the first sign that something is wrong, therefore it's important not to miss it. Perhaps delirium should be the red flag for dementia that unexplained weight loss is for cancer. She is at increased risk of developing dementia in the future. Daniel Davis was the first to show this in a population-based cohort. And I've just shown the same thing, but in a prospective cohort. Even when you control for illness severity, delirium is still associated with an increased risk of dementia. The problem we have is that delirium is often missed. In the point prevalence study I showed you earlier, over half of the delirium that was diagnosed as part of the study wasn't documented by the team looking after them. The only silver lining at a conference like this is that a significant independent predictor of delirium diagnosis was being admitted under the medics, but the rates were still awful, so nothing to celebrate. We know that if your delirium is missed, you do worse. So the key message is it's vital to diagnose delirium, to call it delirium, so none of this acute confusional state, and to document delirium. So how do we do that? Well, the 4AT was designed as a screening tool for delirium, therefore it's brief, it's easy to use, it doesn't need any training, and it's free. It's already embedded in many of the clerking booklets across the country, so many of you will have seen it before. It provides a structured approach to recognise delirium. And they've actually just presented data for its use as a diagnostic tool, not just as a screening tool, and it performed really well even in people with dementia. So as I've got a bit of time, I'll just take you through each part so that you're familiar with it. So you'll see that it closely mirrors the DSM criteria, but kind of operationalises it. So the first part is an assessment of alertness. So essentially it suggests you just go and try and wake up the patient and ask their name. If they're already awake or they wake up quite quickly, then that's normal. If not, then that's clearly abnormal. The second part is an assessment of cognition. So it's simply asking people their age, their date of birth, where they are in the current year, and you score the number of mistakes. The great thing about the 480 is it allows for people who are untestable. So what we mean by this is that some people are too hypoactive, so too sleepy and withdrawn to engage in any kind of testing, and some people are completely the other end of the spectrum. So if they're pacing up and down the ward wielding a stick and things, you're not going to be able to ask them kind of then where they are and things. So it allows for people who are untestable. The third part is a test of attention, and it suggests asking people the months of the year backwards, and if you get to June, that's considered normal. And the final part is an assessment of whether this is an acute change. A score of 4 or more is highly suggestive of delirium. So in summary, delirium is common, serious, and distressing. My study has shown for the first time in a prospective population-based cohort that delirium is associated with an increased risk of cognitive decline and dementia. It's vital to diagnose delirium, to document it, and to communicate this diagnosis with the patient, to their family, and to their GP. And as you'll remember from my earlier slide, studies have shown that delirium is preventable in more than 1/3 of cases. And in the absence of any particularly good ways of either preventing or treating dementia, delirium may be one of the most potentially modifiable risk factors for dementia. So I'd like to thank all of the participants and their families in my study. I'd like to thank my supervisors, my collaborators, and my funder, the Alzheimer's Society, and thank you all for listening.